right, well, welcome. I was wanting to see if we had our welcome video intro, but hey, welcome everyone. Good afternoon and good evening, and welcome to our first webinar Wednesday of 2023. And so we're glad that you're here, taking the time with us to spend. We thought it appropriate to actually do this topic to speak about long COVID after, I'm sure that you all may have heard or read the announcement from President Biden that we're, quote, no longer in pandemic mode as of May 11th. So we thought it was perfect timing to be able to do this presentation. And I also wanted to just share that this webinar is actually being sponsored. Our prime sponsor is NHLBI, and the subrecipients are Cayenne Wellness Center and UC Irvine under their CEAL award. So we're thanking UC Irvine for the opportunity to be a subrecipient so that we can actually put on this webinar for you. So thank you. And if you're new to Cayenne Wellness Center, welcome. And we have a group of compassionate employees that really enjoy what they do, which is working in the sickle cell space. And so we're known for the education that we put on, the support that we have in terms of support groups, advocacy, and some of the initiatives. Just to name a few of the initiatives, last year we launched our Mental Health and Wellness Initiative, where we offer free mental health to all persons in California diagnosed with sickle cell disease and their families. So we're really happy to be able to do that. And that was launched April of last year. This year, we launched STAC, S-T-A-C. You may have been hearing about that. And that's our sickle cell trait awareness campaign. So for the next 5 years, we have a public health campaign here in California where we are targeting middle school, high school, and college age students to know their trait status. But of course, it's for everyone. So that was just recently launched as well in January. And so, and again, we have our annual seminar coming up in September 13th through 16th this year, back in LA, finally. And, we have our Ask the Expert, we have our MINI mini seminars. And so we just welcome you to come on back, find something that has of interest to you, but welcome for today. So I'd like to introduce our first speaker. So I'm really happy. She doesn't know this, but I keep up with everything that she writes. And so I'm excited because the talk, her article was Outcomes in Sickle Cell Disease and Sickle Cell Trait. So Dr. Naik, she has spoken at Cayenne Wellness Center at our summit before. Everyone enjoyed it, so we're welcoming her back. Dr. Naik is an associate professor of medicine at Johns Hopkins University and serves as clinical director of the Division of Hematology and Associate Director for Hematology for the Hematology Oncology Fellowship Program. She holds an undergraduate degree in biomedical electrical engineering from Duke University with honors in research from Cornell University and a master's in health science from Johns Hopkins Bloomberg School of Public Health. She completed her internal medicine residency and hematology fellowship training at Johns Hopkins, where she also served as Assistant Chief of Service Chief Resident. Dr. Naik specializes in treatment of adult patients with a wide array of non-malignant hematologic diseases, including autoimmune cytopenias, coagulation disorders, hemoglobinopathies, and myeloid disorders. Her primary research expertise is in sickle cell disease and in sickle cell trait. That's why she's here. Dr. Naik currently serves as chair of the American Society of Hematology, the Focus Training Program Consortium, which aims to create innovative training pathways and curriculum to increase training recruitment into non-malignant hematology. Dr. Naik, so glad that you're with us. It's on you now. Thank you.
Awesome. Thank you so much, Dr. Rowley, for that wonderful introduction. And welcome to all the webinar attendees. We're very excited to be able to talk about this topic. In fact, actually, this topic of COVID-19 and sickle cell disease and trait came about because I was asked to write a review article. So I have a wonderful hematology fellow trainee who did this with me and actually went through all the literature so that we can share it with you. I'm going to share my screen now. And hopefully you are seeing the correct view. All right, so what I'm going to be talking about today is about COVID-19, its outcomes in both sickle cell disease and sickle cell trait. And this is based on the literature that we have available right now. So we'll start off with a case presentation. This is a very common case of somebody who, a 57-year-old female who has sickle cell disease and hemoglobin SS phenotype, so the most severe form of sickle cell disease, who's admitted with pain in the lower back, bilateral hips, and bilateral thighs. Now that's, it in and of itself is not uncommon, but she reports that in the 3 prior, she had developed fever, rhinorrhea or a runny nose, and a non-productive cough. In the emergency room, she's immediately tested for SARS-CoV-2 infection and tests positive. Initially, while she's in the emergency room, her vitals are stable. She has an okay heart rate, her oxygenation is fine, and she ends up getting admitted to the hospital. But on day 4, she develops worsening dyspnea or shortness of breath and a cough, and then develops a worsening oxygen requirement and ultimately has to be transferred to the ICU. So this case presentation leads to a couple of questions about sickle cell disease and COVID-19 infection. First, what are the outcomes that are associated with COVID-19 infection in patients who have sickle cell disease? And then among those who have sickle cell disease, what are the risk factors that they could possibly have that could lead them to a more severe course with COVID-19 infection? And of course, in the beginning of the pandemic, this was of utmost importance to a lot of us who take care of sickle cell disease patients. So there have been a handful, I would say, of studies looking at sickle cell disease and its ultimate outcomes. However, in order for us to really know, is there an increased risk of something being associated with sickle cell disease, we have to be able to compare it to a normal population. And that is harder. And sorry, by normal, I mean those individuals who don't have sickle cell disease, but yet are still hospitalized. So how do we figure out these sort of outcomes? There have been a couple of larger studies that have been done, and the 2 that are noted here are one that was performed in New York and one that was performed in the UK. The one in New York had 15 hospitals of all New York City hospitals, and it looked at patients from January 2020 to January 2021. Now, while you're listening to all the studies that I talk about during this webinar, I want you to be very careful to look at the dates at which that study was done, because that really impacts what type of COVID infection and COVID variant was most prevalent at that time. So this is very early into the pandemic. This study looked at 12,659 patients who had COVID-19, but even among those, you can see that there was only a small number of them who had sickle cell disease because we're looking in a big population of patients who are hospitalized. So only 53 of them had sickle cell disease. But even with that, they were able to find that individuals with sickle cell disease had a 3.5 times more increased likelihood of actually having to visit an emergency room when they had COVID-19. And then they were 7 times more likely to be hospitalized. And that in and of itself is probably not that surprising, given that a lot of our patients with sickle cell disease do develop symptoms with COVID-19. And we'll go into some of those symptoms later. Similarly, in the UK database, which again this was a primary care database of 1,317 general practices where they just input information. And again, this is early in the pandemic, January 2020 to September 2020, but had 12 million individuals, they found that those who had sickle cell disease were 4 times more likely to be hospitalized. So we can take these numbers to probably be true. But the question has always been, okay, let's say that those who have sickle cell disease are more likely to be hospitalized. Does that in fact mean that they're more likely to develop a more severe form of COVID? And that question is a little bit less well answered. And that's because the absolute numbers of these are actually quite small. So there's really not a clear indication of whether those individuals who have sickle cell disease are at higher risk of severe illness, things like ICU admission, needing mechanical ventilation or being on a ventilator, or death compared to those without. There is that one UK study that was able to actually look at that risk of death. And it did seem that there was about a 2.5-fold increased risk of death among those with sickle cell disease compared to those without. But just keep in mind that there's a big caveat to that. And the caveat is that there was a really small absolute number of deaths in those who had sickle cell disease. There were only 10 people who died in this multi-million person study. And so even though, yes, there is an increased risk, we're still talking about very small absolute numbers. And it is not completely clear whether there was an increased risk of death or not. Registry data also has been done, meaning there have been several registries where people have input their data about their patients who have sickle cell disease. That, of course, is only one-sided. It's showing those who have sickle cell disease, but not comparing it to any other group. And those also seem to have an increased risk of death if you were to compare to the normal the numbers in non-sickle cell disease patients. However, that kind of contrasts with some of the case series and case reports that have been reported, where a lot of individuals with sickle cell disease actually have just mild to moderate COVID-19 symptoms. So it's a little bit up in the air as to whether there is severe disease, but for sure there are some individuals with sickle cell disease who do develop severe disease. So what are those risk factors for developing severe illness in sickle cell disease? Well, that registry data, which we otherwise couldn't use much to compare between those with sickle cell disease and those without, we can use when we're looking at individuals with sickle cell disease and what among them makes them more likely to develop an acute illness or a severe illness. Now, it's not surprising to know that older age is one of the biggest risk factors. So if you were to look in the registry data, it's about 8 times more likely that you're going to need to get intubated or be on a mechanical ventilator or die if you are a sickle cell disease patient who is greater than 40 years old compared to if you are only 20 to 40 years old. So for sure, the older you are, the more likely you are to develop severe disease. And part of that may be due to the fact that if you are older with sickle cell disease and you have had a lifelong history of having sickle cell disease and microvasoocclusion in many organs, that you already have some pre-existing organ damage. And for sure, that organ damage can lead to an increased risk of COVID-19. And this is also from registry data. So the specific types of organ damage that do result in more severe illness are things like pulmonary hypertension, so high blood pressure in the lungs, which again, COVID-19 most illness, congestive heart failure, which also makes sense because this is affecting the cardiopulmonary system, chronic kidney disease, and those who had stroke. If you have any risk factors and you have sickle cell disease, you are more likely to develop severe illness or death. And of course, this is both because individuals with sickle cell disease have these comorbidities, but also because if you had a stroke or had one of these other illnesses in the past, it's more likely that you have severe disease even when you get COVID-19. So now the Secure Sickle Cell Disease Registry was one of the biggest registries and was actually started in Wisconsin. And it was an international registry where they had people from the beginning of the pandemic, providers, input their data on their sickle cell disease patients and those who developed COVID. Again, this was sort of in the beginning of the pandemic from March 2020 to March 2021, but they had 750 cases. And by allowing the physicians to actually input their cases, they were able to look at what are the most common presenting symptoms if somebody comes in with COVID-19 and has sickle cell disease. Well, the most common symptom by and large is pain. And that may in part explain why there are patients who have sickle cell disease who get hospitalized more commonly than somebody who doesn't have sickle cell disease, because pain happens to be something that is the most prominent symptom. And the second most prominent symptom was actually acute chest syndrome. And of course, as we know, acute chest syndrome is a rapid lung injury that occurs in response to either respiratory illness or other types of injury, and can ultimately lead to death. So the fact that these two things are the most common certainly suggests that there may be more severe disease in sickle cell disease. Now, the question is always, also among those who have sickle cell disease, we know that the type of sickle cell disease, or your genotype, can influence whether or not you develop severe disease or not. So in the case presentation that we had, the patient herself had hemoglobin SS disease, or the most severe genotype. But the question is, among those with sickle cell disease, who seems to develop the worst type of disease? And it was a very interesting finding that they found in this French cohort. So there were 36 centers from France, again, early in the pandemic, from March 2020 to May 2021. And they had 319 patients who had sickle cell disease and confirmed COVID-19 infection that required hospitalization. And interestingly, what they found that when they were looking at genotype is that they found that hemoglobin SC disease, or the least severe form of sickle cell disease, had a 7-fold increased risk of death compared to the hemoglobin SS genotype, or the more severe form. And most people would have hypothesized that it would have been the opposite of that. So the question remains, why would those who have a less severe form of sickle cell disease in general have a higher risk of death? And the hypothesis was that perhaps there was an increased risk of clots in the lungs in those patients who had SC disease. So when they looked at their data, they found that 28% of those individuals who had hemoglobin SC disease actually had a clot, compared to only 6% of those who had SS. So perhaps there is some type of synergy between COVID-19 and thrombosis risk in those who have hemoglobin SC disease. So to talk a little bit about thrombosis risk or venous thromboembolism in COVID-19, we have to just look at all of the literature that's been out there. I'm sure many of you on this webinar have heard that COVID-19 does lead to an increased risk of thrombosis. And there have been many different studies that have been performed looking at this. And in fact, there was recently a systematic review pooling all the data from the various studies, because there's been a lot of conflicting data in this realm. So this systematic review looked at 91 studies that included 35,000 patients who had COVID-19. Again, this was early in the pandemic, so looking at all of these studies that showed something about venous thromboembolism. And they found that among those who have COVID-19 infection that require hospitalization, about 8% of them develop a venous thromboembolism. And that means either a clot in the legs or a clot. That is about 3-fold increased risk higher than if you compare to other critically ill populations. So COVID-19 seems to increase your overall thrombotic risk. And that is particularly important in sickle cell disease, because sickle cell disease in and of itself is a hypercoagulable state, or leads to an increased risk of thrombosis. And I'm going to go over that data about the increased risk of thrombosis in sickle cell disease next. So why is there an increased risk of thrombosis in sickle cell disease? Well, it turns out that the red blood cell itself is what's causing the issue. So as we know, there are 3 things that actually lead to an increased risk of clotting. And these things are relatively intuitive. So one, if the vessel that red blood cells are going through and that get clotted, if that vessel itself gets injured, that's a problem. And for sure in sickle cell disease, vessels get damaged, partially because we have sickling of the cells and then occlusion of those vessels, or closing up of those vessels, that ultimately lead to direct vascular damage. So that's hit number 1. The second one is stasis. If our blood can't flow, our blood's going to clot. And in the case of sickle cell disease, when there is vaso-occlusion, that leads to stasis, or an inability of the blood to flow. And so automatically there's an increased risk of clotting. And then the third one, which is also very important, is that sickle cell disease itself leads to an increased risk of coagulation or making the coagulation cascade go off. That is because the red cell itself, when it is misshapen and becomes in a sickled form, it can directly activate coagulation in and of itself. And so those three things put together make individuals with sickle cell disease at a higher risk of clotting. We looked at this a long time ago in our Hopkins cohort to try to see how often are people who have sickle cell disease developing clots. And it turns out that by the age of 30, or around an average age of 30, about 25% of individuals will have had a clot. And that is very high, and especially for a pretty young population. And you can see in this pie chart here that even if you were to think about perhaps it could be related to catheters, only a very small minority of those clots are related to catheters. The rest of them just seem to be inherent to individuals who have sickle cell disease. And then further, when you look at the type of clot that individuals with sickle cell disease get, the very interesting thing is, and there's where the two arrows are pointing, is that more than half of them actually develop a clot in the lungs and not just in the legs. So about 25% of that pie, those people with sickle cell disease are diagnosed with a pulmonary embolism only. But in another about 25%, they have a pulmonary embolism and a lower extremity clot. Now, the reason why this is very unusual is because if we were to look at populations in general and what their clots look like, the majority of the time they actually have more clots in the legs than they do in the lungs. And in sickle cell disease, it is the opposite. And as is probably very obvious to this group, if you get a clot in the lungs, it can have more morbidity or more problems associated with it. So even the risk of thrombosis in sickle cell disease is high, and so is the morbidity or the complications that can occur with those clots. We also looked in the cooperative study of sickle cell disease, which is the largest registry of sickle cell disease in the 70s and 80s. And in fact, we found that if by age 40, that 11%, over time, 11% of individuals with sickle cell disease will have had a clot. Now, what's interesting in this study is that it looked like that risk was highest in those who have SS, or the most severe form. However, that is in contrast to what we saw in our Hopkins cohort, where those with hemoglobin SC actually had the highest risk. So the genotype pattern for venous thromboembolism is not completely known. And interestingly, in COVID, it does seem that hemoglobin SC group, or the lowest severe phenotype group, is the one that is affected the most. So it's really unclear what are the different factors. Is it how thick the blood is? Is it how high the hemoglobin is? Is it how much you're hemolyzing or breaking up your blood? That's the most important in venous thromboembolism. Now, looking at how hypercoagulable you are when you have sickle cell disease, I just want to point out that this is the curves right here for how many people develop sickle cell disease. Hopefully you can see my cursor. And then there is another type of thrombophilic state, or another hypercoagulable state known as factor V Leiden. And that curve starts only going up around age 60, whereas you can see here in sickle cell disease, the curve actually starts to go up right around the 20s. So people with sickle cell disease are at an increased risk of developing venous thromboembolism very early in their lives. And this is in contrast to many other hypercoagulable states that we talk about. This is just bringing home that the risk of developing pulmonary embolism or clot in the lungs is about twice that of developing a isolated clot in the legs. And that is very different than what we see in the general population. And so this is something important to remember, especially when it comes to COVID infection. If we are worried about getting clots in the lungs, then it can lead to increased morbidity over time. In fact, they actually looked in this cohort to see, is it hospitalization alone? So that's another big question. If you're in the hospital and you have COVID-19 infection, is it the hospitalization that was leading to the risk of thrombosis? Or was it the sickle cell disease itself that led to that? In this study, they compared individuals who were in the hospital for sickle cell disease compared to those who were in the hospital for an asthma exacerbation. And they found actually that sickle cell disease patients, those are the two red lines on the top, definitely are at increased risk of developing pulmonary embolism compared to those who were just hospitalized with asthma. So it does seem that the sickle cell disease itself is the problem and not just the hospitalization. Now I'm going to just switch over to sickle cell trait. And a lot of what I talked about in sickle cell disease ultimately pertains to sickle cell trait, but at a lesser degree. And that is not completely unexpected, given that sickle cell trait is generally a very benign carrier state and not something that we worry about. Now, there was a hypothesis that sickle cell trait may lead to an increased risk of COVID-19, severe COVID-19 outcomes. And part of that has to do, one, with the fact that sickle cell trait has an increased risk of pulmonary embolism or thrombus, like we were just talking about. And two, because there has been some scant data of sickle cell disease, sickle cell trait being associated with other outcomes, and is something that is one of my research interests. So in the UK, that large UK study that we were talking about that had over 12 million individuals, there were 25,682 individuals who had sickle cell trait. Now, this is with the caveat that I'm not 100% sure how they figured out that those people had sickle cell trait, because as you and I both know, many people don't know their own sickle cell trait status. So how they decided, they figured that out in this study is a little bit unclear to me. That being said, they found that yes, there was an increased risk of hospitalization and death in sickle cell trait compared to individuals who didn't have sickle cell trait, but that those risks were much lower than that in sickle cell disease. And again, when you look at this death on the bottom here, and you're looking at the confidence intervals here for how confident are we in these estimates that we're doing, the sickle cell disease and sickle cell trait kind of overlap. And part of the reason for that is there's very few deaths in those two groups. And so it's really hard to tell, is this a true estimate or not? But it certainly does seem that there probably is a little bit of an increased risk of hospitalization and death in individuals who have sickle cell trait. And the question is, what is causing that death in sickle cell trait? Is it the sickle cell trait itself that's doing it? That seems kind of strange. Or is there something else that's happening in the middle? And this study tried to get to that very particular question. So this is using the Million Veterans Program study that had 132,000 participants who had COVID-19 information. About 3,000 of them had sickle cell trait, and of those, about 353 actually had sickle cell trait and COVID. Again, this was early in the pandemic, and they found the same as that other UK study, that there's about a 1.5 to 1.7-fold increased risk of death among individuals with sickle cell trait compared to those without. And this estimate is actually a little bit more accurate, partially because they actually genotyped those individuals for sickle cell trait and could verify that they had it. Now, when they tried to figure out why did those individuals with sickle cell trait die? Because again, sickle cell trait in and of itself is not a disease. What they found is that sickle cell trait actually was associated with an increased risk of acute kidney failure while an individual had COVID-19 infection. And they were able to do some fancy statistics to show that about 20% of that the total effect of the death, so the death, 20% of that could be explained by this acute kidney injury. So it really seems that kidney injury is part of the reason why sickle cell trait individuals can be at increased risk of death in COVID-19 and severe illness. And they found that these are the two particular risk factors. If you had pre-existing chronic kidney disease, or if you had pre-existing pulmonary embolism and you had sickle cell trait, you were more likely to develop severe illness. And that's not completely unexpected. But now I'm going to show you the data about why does sickle cell trait lead to kidney disease and to venous thromboembolism. And that will try to help inform why this can happen in COVID-19. So as I mentioned, sickling does not occur in sickle cell trait under normal conditions. It never does. However, in certain types of conditions, these are very old studies looking at low oxygen tension in a test tube. They gave a very little oxygen, or they changed the pH in a test tube, and they said, how much do we have to stress this red blood cell to really make it sickle in sickle cell trait? And it turns out there's two conditions that can do that. If there's very low oxygen or extreme hypoxia, if it's very acidotic, there's a low pH, that's going to cause it. And in the body, there's only very few places in the body at which the conditions ever get that low. And one of them happens to be the kidneys. So this is a very old study that looked at the renal vasculature or the kidney vasculature in those who are healthy, who have sickle cell trait, and then who have sickle cell disease. And you can definitely see that in a healthy individual, those vessels look nice and straight. In somebody who has sickle cell trait, they definitely have some damage, but it's much worse in sickle cell disease. So it seems like, yes, there is something happening in sickle cell trait, albeit less than that in sickle cell disease. So why does that happen in the kidney? It's because the kidney has those particular conditions that can lead to sickling in sickle cell trait. So the first reason is because the kidney consumes the most amount of oxygen in the body compared to any other organ. That means it has the least amount of oxygen available, and that can lead to sickling. In addition, this one particular part of the kidney, the renal medulla, actually is the most acidotic place in the body, the most dehydrated, doesn't have, because it's trying to reabsorb water, the least amount of water, and has the lowest oxygen tension. So all of that is going to promote sickling and sickle cell trait. So it's happening only in that organ, not throughout the body. And that's very important to emphasize. In order to see, does that lead to an ultimate problem with kidney disease? We looked in very many studies, even prior to these COVID-19 studies, to see, is sickle cell trait associated with kidney disease in many different settings. And we use these large NHLBI cohorts or NIH cohorts that have been following patients over time. And these were very different studies. These were studies, the ERIC study was an older population. JHS is all Black Americans. WHI is all women. CARDIA is all young adults. And then MESA is a multi-ethnic cohort. To see, does sickle cell trait influence kidney disease in all of these populations in the same way? And in fact, it does. It leads to about a 1.8-fold increased risk of kidney disease if you have sickle cell trait compared to if you don't. So for sure, sickle cell trait can lead to kidney disease. And obviously in the setting of COVID-19, it can lead to kidney disease that can ultimately lead to more severe COVID-19 infection. Now, the other question is, does it ultimately lead to an increased risk of developing end-stage renal disease or needing to be on dialysis? And we used another cohort to show that. This is called the Regards cohort. And you can see all of the individuals that were in this cohort that are represented by all those blue and red dots. When we looked in that, we also found the same sort of association, that there's a twofold increased risk of an individual with sickle cell trait developing kidney disease and needing to be on dialysis compared to if you don't have sickle cell trait. So for sure, all of this damage that's occurring within the kidneys can lead to kidney failure over time. And then the question, of course, is, well, what about the case of clotting? We talked about clotting in sickle cell disease. Why would this happen in sickle cell trait? First, we had to see, is it happening in sickle cell trait? And we used this study to look at it. And we looked first here to see the dotted line here is sickle cell trait. Do individuals with sickle cell trait develop venous thromboembolism more commonly? The lower you go, the more events you're having. So it certainly seems that they're having more events than if you don't have sickle cell trait. And then when we look specifically, are those occurring in the lungs or are they occurring in the legs? You can see that the majority of those events are actually occurring in the lungs, and that the legs for those who have sickle cell trait and those without are about the same. So this has the same sort of phenotype that we see in sickle cell disease. We're not sure exactly why it's happening, but again, when I said there's certain parts of the body where it can be very low oxygen tension, where there can be promotion of sickling. One of those areas is actually in the valves of the legs. And when you get a clot in the valves of the legs, it's more likely to go up into the lungs. And so that is one hypothesis as to why sickle cell trait may lead to an increased risk of clots in the lungs. And of course, in the setting of COVID, this could lead to an increased risk of severe complications. Now, I mentioned that all of these have to be taken with a caveat of when all of these studies were initially done, it was very early in the pandemic. That means those early variants that include the Delta variant. And those death rate is down here. You can see that the death rate was actually highest in the early period and now has sort of tapered down. So many of these, it's not clear exactly what's causing it. Most likely the variant itself is partially contributing to it. So the viruses tend to change to become less severe, and they also tend to change to become more infectious, but less severe. So it's possible that a lot of these things that we noticed early in the pandemic are not currently going to cause problems in sickle cell disease patients going forward. And in fact, now the most common COVID variant is Omicron, which tends to be the least severe. I know that Dr. Su will be talking a lot more about COVID epidemiology after this. So I'm going to leave you now with some conclusions from this talk. So patients with sickle cell disease are more likely to be hospitalized with COVID-19 compared to those patients without. Patients with sickle cell disease likely do have an increased risk of severe illness, though that's kind of up in the air. Risk factors include age, comorbidities, hemoglobin SC genotype, and there may be an increased risk of thrombosis among those, especially with those with a SC genotype. And similarly, sickle cell trait is associated with an increased risk of COVID-19 related severe illness and death. And it seems that development of acute kidney injury is part of the reason for why that can happen. But remember and keep in mind that all of these outcomes may be less severe with these more recent COVID-19 variants. And I'm just going to leave with a thank you slide to my fellow. This is my fellow, Jana Christian, who actually went through all this literature and wrote the research article. Thank you very much.
Wow. How enlightening. We're going to ask those to please write your questions. So here's what's interesting. I know that for sickle cell disease, it is SC, hemoglobin SC, pulmonary embolism, age. With trait, because it's already leaning towards kidney injury, PE, but does age play a role? I didn't see that.
Yeah, it wasn't quite as clear, but likely, yes. Age in general is a risk factor, yes.
Okay. And then the other thing that I found fascinating that I didn't know, you were saying that for the kidneys, it takes a lot of oxygen, of all of the organs, and I would have thought the brain, but it's the kidneys that require the most amount of oxygen, correct?
It's the renal medulla that has the lowest oxygen tension in general. Yes, you're absolutely right. Mm-hmm.
And so therefore I can see why then that would be a hit. That would be the first place for injury or what have you to occur. Wow. Okay. Well, I think that the information was very fascinating. Again, one of the reasons that we're wanting to do this is because COVID came, it's still with us. And so I think it behooves us to have an understanding of the long-term effects. My last question is, so in knowing this, what can those persons who have higher risk do? Are there preventative measures that they can actually take since they actually have a higher risk? Are there any things that you can actually share with us?
Well, I know that Dr. Su is going to be talking a little bit about this as well. But yes, I think there are certain things that we can do that are, so for example, with the venous thromboembolism risk, there is making sure that all your patients are on prophylaxis. If they are hospitalized and have COVID infection, in general, there isn't robust data in sickle cell disease in particular. So we're using just the guidelines we have for any sickle cell disease patient who is hospitalized, but you have to be very cognizant of that risk. And then in terms of other things that we can do, like vaccinations and things like that, I know Dr. Su is going to talk about that next.
Wonderful. All right. Well, just checking to see if we have any questions. And I don't see anything in the Q&A at the moment. So what we'll do is, I'm sure that there will be go ahead and write them into the chat or the Q&A. I know we have people who are on live stream. So go ahead and do that. And while you do that, I'm going to introduce Dr. Sue. And many of you might know Dr. Sue as the Chief Medical Officer of SDDAA. And also early on in COVID, I don't know if you all remember, we had several webinars looking at COVID and vaccine, and there were questions about it. And so we had at least 3 or 4. But if I can just read his bio. Dr. Sue is a pediatric hematologist who's dedicated to finding cures for sickle cell disease and to improving treatment and education until cures can be found. He joined UIC as director of the Sickle Cell Center and professor of pediatrics in July 2011. And he's led large pediatric sickle cell programs at Emory University and St. Christopher's Hospital for Children, and also Children's National Medical Center. His clinical and translational research experience include multi-center landmark clinical trials of sickle cell stroke prevention and bone marrow transplantation. He's published over 50 peer-reviewed papers, including co-authored a book now in its 3rd edition entitled Hope and Destiny, The Patient and Parent's Guide to Sickle Cell Disease and Sickle Cell Trait. So as a plug, we actually buy them by the hundreds. And when we have our warriors do our Sickle Cell 101, we put that in a backpack. And so those books are put in the backpacks along with spirometers, thermometers, and blankets. So many of you are probably familiar with the book. In addition to sickle cell disease, his clinical interests include thalassemia and adolescent transition. Among his research interests are sickle cell disease, health education, bone marrow transplantation, and health disparities. In addition to English, Dr. Sue also speaks Spanish, Mandarin Chinese, and a little Portuguese. So, hola and bem-vindo, right? That's hello and welcome.
Okay. Buenas noches, and thank you very much. And thank you, Dr. Naik. I actually went to Cornell. I was an engineer there too, a long time ago. So thank you all for the opportunity. I'm going to see if I can share the screen here. And 3, 2, 1. I hope it's coming.
It doesn't show it shows like a Zoom screen broadcast.
Yeah. How's that?
Yes, you got it.
Yes.
Okay.
Great.
All right. So this is going to have a different flavor than Dr. Naik's. I don't have really as much data, and this is going to be marching through more of concepts. This is my disclosures that I do research, I do consulting. I'm not going to talk about off-label use, but we're going to be discussing publicly available information and progress in sickle cell. So my case, I'm in pediatrics. And so as you remember, COVID pandemic, everything was in lockdown in early 2020. And so I was getting phone calls and messages like this in July of 2020, that there would be this teenage patient of mine who's having many days of sickle cell pain that was really severe, 9 on a scale of 10. And he's running out of his prescription pain meds, but this teen patient is refusing, telling his mom, I won't go to the hospital because I'm gonna die of COVID if I go to that hospital. And this was the scenario in 2020, that everybody was terrified of how bad COVID was going to affect them, and really associated COVID with pretty much like immediate death. But what we're facing right now is that this is a map of the world from World Health Organization from yesterday, showing the distribution of how much there has been COVID over the course of the past 3 years. Darker colors, meaning that there's more cases. And then they have a log at the World Health Organization where they claim to have counts down to the exact number of persons. I doubt that that's really the case, but the log shows these unbelievably huge numbers. 766 million people have had COVID. 6,900,000 have died. That's, you know, the entire population of a small country, or the population of a large metro area like Chicagoland. But there is some good news too, that there have been 13 billion with a B, vaccine doses administered. And if you compare that to the total world population of 8 billion, that means there's been more than one vaccine dose per person on average. And that in the last 7 days, the rates of infection have diminished compared to the huge numbers that we were having earlier on. The data trackers from the Centers for Disease Control show that trends for hospitalizations are down, heading down and down and down. That line is just sloping on downward, and the deaths are also sloping downward. Although there's maybe a little blip upward in the last week, which is puzzling, but hopefully it'll turn back around again. It also mentions that for the entire population of the United States, 17% have had an updated booster dose. So this is getting the latest recommendations. But overall, in the United States, the rates of COVID hospitalizations have been declining. So in this map that the CDC would keep on publishing, and it'll be carried by the New York Times and everything else, it used to be that the vast majority of the country was lit up in orange colors or yellow colors, and you couldn't travel here and you couldn't travel there, as well as your own state was orange or yellow. I couldn't go into where my parents, who are senior citizens, are because they were in a state of lockdown for like almost a year. My mother-in-law with dementia was also in a state of lockdown for almost a year because everything was orange. But now things are almost all green, almost all with a relatively low rate of cases. And then there is this pattern of these variants that different types of COVID virus have been marching through, and then it keeps on changing, and then it changes some more, and then it changes some more. And you have these lovely artistic graphs that show that over the course of 18 months of tracking, there's been these different colors that show up as being taller, meaning that there's more cases of this kind of variant, and then it falls away over a few weeks, and then another color becomes taller, and then it falls away, and it's just like wave after wave, like waves hitting the beach. And it looks in this thing that, you know, there's like 9 colors here, but at least 6 major types of variants have come through over the past year and a half. And as Dr. Naik was mentioning, the patterns of how much infection they cause, the patterns of how much death they cause can be different from one variant to another. And you may have one variant that's not as infectious, but more lethal. And then another that's more contagious, but it doesn't kill you as much. And so we've seen those kinds of things go through. And I have frankly lost track of which letters and numbers are what. And so I just put them in the fine print, so I can't even see them on the screen right now. But they're all related to each other, shown in this upper right-hand corner with the sort of family tree of different viruses, who begat who. And then we have this thing called long COVID, more than 30 days or more than 6 months. There's something called post-acute sequelae of COVID, PASC. It has made me completely dizzy trying to keep up with this, because when you look at summaries of literature, they say that over 200 types of symptoms have been reported in this patterns of different long COVID. I talked to my relatives or my staff or my friends, and this one had like numbness. This one lost his smell. This one lost his taste. He couldn't taste the beer that he was making. He was very, very bummed. Another one is a singer, lost his control of his muscles, so he couldn't sing very well, or he could only sing for a few minutes where he was trying to record an album. Just didn't work. He had to put off the recording session for like half a year until he could recover. Other people have had brain fog, weird stuff that is just extreme fatigue, unable to get out of bed, or profound mental status, mental behavioral type of health type of problems. But it doesn't seem like everybody fits into one pattern. And then it does seem like these are were more common in the early pandemic than they have been later. There's studies now that link the long COVID to a higher inflammatory response, that maybe the time that you get this the person who has the most intense inflammation by their body when the virus is hitting, that seems to do something that is associated with this long COVID. But exactly what that is, people are still trying to figure that out. And then, Dr. Rowley asked us to talk about long COVID and sickle cell disease, but there's barely any organized reporting of long COVID and sickle cell disease. So that probably we're going to have to mount either a registry or a survey, a poll, in order to really capture the information. So that right now, this is about all we know. All I can say for long COVID and sickle cell disease is that it's very sparse reports. We don't have tons and tons and tons of people with sickle cell disease with long COVID. I think we would have noticed if that happened. But exactly how much, whether it's increased compared to the general population or decreased compared to the general population, increase versus sickle trait or decrease versus sickle trait, I don't think we can know yet. So I'm going to turn to the other question that she posed, which is, so you're facing these risks, what can you do about it? So here's what you can do about it, shown in the blue, vaccination. So people have heard of vaccines, and the vaccines showed efficacy in the clinical trials. They showed that they were able to bring people's antibodies up against the COVID virus, and that they were able to do that really quite well, better than expected, better than people had seen with other more ordinary vaccines. And so that you could get protective antibody levels very, very much in the neighborhood of like 90% of the time, and in pretty short order, in just a few days. And so as soon as this was announced, the medical system, the public health system, the government, and many, many people just basically said, the only question we're going to ask is, which arm do you want injected with the vaccine? And there were announcements by people who are vaccinologists, such as Dr. Paul Offut, people like me getting vaccines as soon as we could, because we wanted to be able to take care of our patients without being sick ourselves and spreading it to more people. Can you recognize who is the gentleman here, shown here, with the mask, getting his shot? You can read in the caption. So this is from my hometown, Chicago, and Dr. Reverend Jesse Jackson was getting his vaccine at Roseland Community Hospital, which is right in the midst of the south side of Chicago, and really showing that here is a leader in the community getting his vaccine. Here is Dr. Kizzy Corbett, a Black woman who is working at the National Institutes of Health, one of the pioneering scientists who helped to make the vaccine possible, lending a supportive hand on his shoulder while he gets his vaccine. And so it's really trying to show, like, get the vaccine, get the vaccine, get the vaccine. But objections started to show up, both in things that sounded like, okay, maybe a reasonable concern, like COVID vaccines, I want to wait for it to be out a while before my child gets it. But then how long to wait? Some people were saying they want to wait a few weeks. Some people want to say a few years. Then you hear concerns that people say, I heard that the vaccine is going to change the DNA. And then some people were worried about the side effects and the news and about heart inflammation. And why go looking for trouble? Trouble will find me. I don't have to go looking for trouble. But these days, there's better data now that COVID vaccines, because there's been millions and millions. You saw 13 billion people have gotten vaccines now, or there's been 13 billion shots. That with COVID vaccination, the general population, not just sickle cell, but the general population has a lower risk of hospitalization with COVID infection, lower risk of death, lower risk of this long COVID or the PASC, and lower risk of transmission to friends and family. So it does not seem that having a COVID vaccine guarantees you will not catch COVID at all. That, unfortunately, we cannot claim very well because people have seen that for sure. I think that's because there's so many different variants that are rolling through, so that your vaccine's response is not quite enough to protect you against the next guy that is a little bit different because it's already mutated a little over past half year, or that your antibodies wane a little bit and you have to get another booster. But the vaccines do seem to really be able to protect against many of the much more serious problems that can come with the COVID infection. So again, decreased chances of hospitalization, of death, of long COVID, and lower risk of transmission to friends and family. But what we've been hearing is that some people are still saying, did you hear about the vaccines? And then they get these campaigns of, did you hear this? And did you hear that? And then, you know, almost like the game that you can play called telephone, or try to pass along a message, and how goofy the message gets by the end of the table of 6 transmissions of the message, one by word of mouth. You're getting rumors and confusion. Hank Aaron, did you know he died of COVID vaccine? Or COVID vaccines have Satan's microchips. COVID vaccines bad for women. All this were not accurate information. And so there has been a little bit delayed now. There has been now more of an idea that when you put out a vaccine as something that you want to do on a massive, massive scale, you also have some structure to be able to get the message out, almost like a marketing campaign. If you had, for example, a new version of a soft drink, people know I'm from Atlanta, you know what kind of soft drink comes to mind automatically for an Atlantan. If you have a new soft drink from this company that's based in Atlanta, they will for sure have a big old marketing campaign to make sure everybody knows about it. They've tested the market, they craft the message precisely, they try to answer everybody's questions, they get feedback, they adjust the marketing message. That had not really happened with the COVID vaccine as they were rolling it out. And so now, as people are doing in retrospect, or in the later parts of this whole campaign, trying to set up an implementation science and dissemination framework. And there are things that people who have been studying implementation science do, where they try to use in the left-hand column here, getting stakeholder input, evaluating the process, prepare for changing conditions or changing behaviors, and overcome social determinants of health. Maybe you put the vaccines out there at the hospital first, but not everybody gets to the hospital. So now you put it at the American Legion Center and at the school gym. In Chicago, they would put it also into community health centers or in a church basement. My church's basement was doing this for like 9 months, and my wife was sitting there with other church volunteers, drawing up vial shot after shot from the different vials and giving it to people who would come for the vaccine, because they knew it was being given in the church that they also go to. And so things like that were gradually being built up. But these fit into implementation science framework shown on the right-hand side that people were learning in retrospect. There's also now a different way of giving the conversation, how to present the information. Instead of just saying, here's a vaccine, come and get it. Now is to try to have a well-framed conversation about that. How do we say it? What we say, how we say it, what we emphasize, and what we leave unsaid are all part of what you call framing the conversation. And that this can be helpful or hurtful hindrance for all kinds of vaccines. And this is coming from, my pediatric society. So it's talking about children and adolescents, but it's really for everybody too. So the challenge right now in many vaccine administration campaigns is that people are thinking about health and illness as primarily something like an individual choice, almost like which type of spinach do I choose? Or do I buy spinach at all? And they don't think about the broader societal effects. And so people in the general public believe that they and their children can make all the right health choices, such as what you eat, spinach, kale, whatever, whether they take vitamins, whether they smoke or not, whether they inhale or not, which kind of marijuana they're choosing. And then their immune systems could be strong. And then they kind of feel like, well, I can choose the organic spinach versus the not organic spinach versus the kale. And I can choose vaccine versus not vaccine, and that is optional. And so if people only think in that kind of context, then it becomes extremely individualized, and you lose the idea that I'm part of a society where, unlike the spinach, like my neighbor doesn't care if I had organic spinach or not organic spinach. But my neighbor, if they're riding the same elevator with me, they probably do care whether I have COVID or not. Again, if they're on the same elevator, they don't care which spinach I got, but they do care if I'm actively infectious to them. So that having infections is something that's really a social issue and a social problem. And so shifting now the discussion about vaccines from the individual to the collective also shifts the focus of the vaccine from fighting disease to how the immune system can prepare itself. So I talked about how it could decrease your chances of death, long COVID, hospitalization, but also transmitting it to your friends or your family. If I get vaccines, I'm more able to go into the senior citizen center. If I get vaccines, I'm more able to take care of my patients. If I don't get vaccines and 7,000 other people in my city don't get vaccines, the emergency room is going to be crowded. And that person who comes in with a gunshot wound or a motorcycle accident will have to wait longer, or the blood supply is not enough to take care of them because there's so many people with COVID that have to be taken care of, perhaps because they didn't get the vaccine. Whereas if they got a vaccine, they didn't get hospitalized. Remember that statement? And so now you have more space for the motorcycle accident to get cared for, or for my neighbor's heart attack. Heart attacks were having to wait because the emergency rooms are so crowded by COVID. So again, talking about vaccines can be more about talking about the common good of the society, and then about the individual benefits. And so you can have package phrases like, everyone in our community deserves to be healthy, and part of being healthy means getting vaccinated, and it benefits all of us if every child in our community is vaccinated, because it means that all of us are more likely to be healthy. So there's now strategic briefs, packaged statements, and coaching types of things for pediatricians that talks about how do you communicate about vaccines, about it being for the common good, about preventive health type of measures, that you may not feel that it's good for you just at the start, just like you may not feel it's good for you when you start on a journey climbing up this lovely mountain. But when you get to the top, you realize, oh yeah, that was worth the whole trip. Going over the little rocks and going over the things where it's not such a great scenery, because I finally get to the end, which is good scenery. And we're all responsible for making that happen. One way that is suggested is to change the description of what the vaccine does, and that getting vaccinated, actually getting a vaccine against a virus, is like updating your computer or your phone with an antiviral software. Partly is for your own good, but you know it's partially also for the good of everybody you're communicating with. Because if you send messages to uncles, aunts, cousins, friends, and you're sending viruses with your messages, they're going to notice that this came from you. So getting vaccinated for your phone or for your computer is something that we actually do fairly religiously. You know, my wife will tell me, hey, this new update came out, you better update it. And she'll watch me until I update it, because she doesn't want to catch whatever computer virus I might have. So just like our computers need to know how to detect a virus after they received a software update, the body can remember how to detect and react to a virus even after that vaccine has left the body, because it's an antiviral protection. Another way to describe the vaccines is it's like learning to read and write. Once you've taught the immune system to read, it reads, oh, this is a coronavirus. Okay, I can sort of recognize this. It wasn't what I was taught to recognize in the first place. It's 85% the same. I think that's still a coronavirus. And so it's learned to read it, it's learned to write it, perhaps. And so having the vaccines is like a practice for reading for the immune system. There's also some people who are now packaging messages specifically for faith-based descriptions. And so there was this Baltimore pastor who, as early as August of 2020, was thinking about how he's going to describe things to his congregation, because he's both a pastor and I think he has an MPH as well. And so he was saying, don't say that, you know, I have faith and therefore I will not get this vaccine. I would just count on God to protect me, be a shield, be my shield and my rock, because I have to have enough faith to really show that. Well, he says, you know, even in scripture, Moses had faith, Noah had faith. There's many, many people who had faith and they had to do some things. And Noah specifically, he was a savior for his family and he was celebrated as a man of great faith. But God didn't just give him an ark to do that. He had to build the ark. He had to put in his own human effort in order to do that. So that's, you know, sometimes God doesn't give you the instant salvation. He didn't pluck the family out of the waters. He had Moses build an ark. So the same way, building vaccines, building treatments is something that sometimes God inspires us. God helps us to do that. Also, Noah had to do a little experiment to be able to get out of the ark. You know, when the rain stopped and the floods were still, you know, there's still a lot of water. So when do you open the ark and come out? So he sent out birds to see whether they had someplace to land, see whether they could scout things out. He didn't have drones, he had birds. And when the birds came back, he knew that things were not quite ready yet. But when the birds came back and one was carrying leaves, then he kind of knew, okay, maybe things are getting ready. And then when they didn't come back, then he knew that it's okay to start to open up the ark. So in summary, talking about vaccines is now going to be reframed as more for the common good, comparable to a computer update or comparable to learning to read. Again, Academy of Pediatrics is going to lead the way on this. Another way that I have been presenting things is as a wanted sign. So kind of reading a sign, telling your immune system, this is what the spike protein looks like. Maybe the virus will mutate and change the color or change the exact number of spikes or their angle, but it's still a spike protein. Look for that spike protein. That's what's on this dangerous hombre who is wanted. So who can get a COVID vaccine? Just about everybody. It used to be from 12 years old and up. Now it's actually from like 5 or even younger and up. And thousands of individuals with sickle cell disease have now had COVID vaccines and have done fine. Many did have some side effects, but they went away by day 3. Only a tiny number had sickle cell pain. Who can get boosters, including 3rd shot and maybe even 4th shot? People with poor antibody production, which includes chronic medical conditions like asplenia, not having a functional spleen, which equals people with sickle cell disease. And then now there's further vaccine discussion about 65 and up, or how many months it is since you had your previous. We're just going to follow general guidelines for that. We're trying to get the word out for most other health things through community health workers, not just people in suits and ties like me. Again, reactions are expected because when you give your first shot, you have to build up some antibodies, and then you get some, and then by the next shot, you have antibodies already there and white cells mounting up. And so then you get some more redness, tenderness, fever, but it will go away in about 3 days. And the latest information from 2023 is that in youngest children, like down to age 5, the reactions are less and less. So it's more reactions in like the adults than in the children. Once again, COVID vaccinated equals lower risks of hospitalization, of death, of long COVID, as well as lower risk of giving it to your friends and family. Here's me getting one. There's the bottom line. Vaccines can help the community and are safer than the disease. The Medical and Research Advisory Committee, MERAC, has been a while since we had any kind of statements about COVID. Probably the next statement will sound rather similar to what I just told you, emphasizing getting vaccines, as well as getting comprehensive care. Take care of your kidneys, take care of your lungs, try to tune them up as well as possible so you don't have the increased risks of these problems. Is COVID risk of sickle cell disease reason enough to work from home? Probably not. If you do have severe organ complications like kidney problems, is that enough reason to work from home? Probably a case by case. And overall, this pandemic has been a long road, but the end is, I think it's here, or it's at least tapering off. And the resilient, like this little tomato plant that's growing out of cracks in the pavement, resilient people have managed to get through this, and we have hope. I will stop there. Thank you very much.
Oh, thank you. And I also just wanted to put in another plug for MERAC. Dr. Sue, if you can talk briefly about that, on the SCDAA site, since the beginning, it's been very helpful for the sickle cell community, even with respect to students and schools. And so I would invite you all, you're right, there hasn't been a latest update, but I would invite you all to, check it out every once in a while. Did you want to share what MERAC means?
Oh, it's a Medical and Research Advisory Committee.
Yes.
MERAC.
Yeah, all right. Well, we do actually have a question. I think most of them have been answered, but there was one from Etta, and I don't see the one from Etta anymore, so I don't see that question. But if there are any questions, feel free to put them in the chat, and we can also acknowledge you. So Mary is there, and if you raise your hand, she can allow you to speak as well. Okay, so the question is, a person with sickle cell disease and another blood issue can't get the COVID shot. What's the next step for them?
That's probably for you to discuss with your doctor. Dr. Naik, can you think of anything else?
I can't. I don't know which specific type of blood disorder you're talking about. You're right. There used to be some, certain types of medications like Evusheld that you used to be able to give if you couldn't get a vaccination. Those are unfortunately not useful against the Omicron variants. But I'm not sure exactly which blood disorder you're talking about. And for sure, just like Dr. Sue said, it would depend on what that was. I do want to just answer, there was another question in here that I answered. Oh, it was Pat Corley, who I think is maybe asking the same question or a different one. Go ahead and ask your question. Oh, can they speak?
I'm not sure if they can speak yet, but we'll just ask the question in case you all didn't see it. Does higher hemoglobin in
Can you hear me?
Oh, yes, we can.
Yeah. Thank you.
Okay, so that was my initial question. But I also wanted to talk about observations that I made in terms of our community related to the conversation around COVID. And I think that, you know, I'm a little bothered by it because I think that there was kind of a disrespect and disregard the African American community, because it's said that people in our community were reluctant to take to be immunized. And the reality was the availability for our communities was really limited. And so initially when they presented it, and then, you know, the frustration of not being, even myself, of not being able to access immunization, people just kind of gave up, and they did start depending on God to protect them. But it was more than just their desire to have to wait on God. It was the absence of availability. It was the disregard for an underserved, sometimes undereducated community that really didn't understand how do you go about getting this, and trying to avoid desperation. And so many folks just kind of backed off on even trying to be immunized. And there was little education done to compare. There were a lot of thoughts about, you know, Tuskegee and stuff. There was little information to explain the difference between Tuskegee, the denial of treatments as compared to COVID immunization. So that I think our government really misstepped, you know, and unfortunately, the communities, the poorer communities and communities of color were made to look like they weren't interested in doing it. We were actually very desperate in many instances within our community to be given the opportunity to be immunized so that we didn't get sick and that we didn't cause illness and death within our families. So I just want that to be heard, because I think there is a picture that's being painted that is not absolutely true.
Thank you, Pat. Yeah, I agree. And I'll add to that there's also a more complicated picture where, because the rollout was not that well organized, there was huge variation from community to community. And so some places, it was clearly how the message was sent out that confused people, or some people didn't hear and other people got wind of something and they were lined up before dawn and used up all the vaccine before somebody else even knew that it was there. And then other places, it was much better organized and set up. And then some places had locally very creative ways to distribute to everywhere, and would have like roving people getting messages out and try to say, okay, at 10 o'clock, we're going to do this. And at 12 o'clock, we're going to go someplace else, and things like that. And some people were just like expecting everybody to show up in a central location. So I think part of what you have seen, Pat, was for your area, and some other areas had really different experiences, and then some places had nothing at all.
Yeah, we actually had, when they would announce vaccines being given, people from other communities way far out of our city would come over early in the morning, and they didn't look like the African American community, and they would take all of the vaccines, and people would not be immunized. And then they would get sick and they would be in the hospitals and they would die. And everybody was like, you know, it's hopeless. So I think we just have to do a better job.
Yeah. Yep. But at the same time, now, 2-3 years later, how much has the message gotten changed? Is it still, you know, I can't get to it, I'm going to die, I'm suspicious, or is it something else now?
It's I survived. Okay.
Yeah.
So it's not really that important anymore.
Well,
Yeah.
So one other thing I thought of just now for the first question about if I have sickle cell plus some other disease that does not allow me to get the vaccine, one other thing you can actually do is encourage the people around you who could get vaccines to make like a little shell around you so that you would have less chance of having it from your immediate contacts. That is actually some of the message about the transmission. And so that is the one thing that could be done.
Thank you. And thank you, Pat, for the question. Okay, and I don't see another question. Oh, no, I don't see another question here. So, and I'm looking at our time. We have about 8 minutes as well to wrap up. I like to take advantage of opportunity. And again, I think this was a good opportunity because unless people paid attention, May 11th was an earmark for the COVID is no longer a pandemic. And I was concerned about that. I mean, I understand what pandemic means, but I was still concerned because I don't want people to now just think, oh, I can just do everything like I used to, because as was reported, there are still deaths. I think I saw 174,000. So it's not that many, but you still have to become aware. And particularly if people have colds and sniffles and coughs and what have you, what can you do to continue to just take care of yourself? If you've made it this far, as like Pat said, you survived, what can you do to continue? And so that's my concern, is those people that survived, what do they attribute it to? And so we don't know. We haven't been able to do a focus group, but I'm curious about that. Is it because you washed your hands and you wore your mask and you got vaccinated? Or was it due to other things that you attributed to, quote, surviving? So again, I think this was timely because I personally still wear my mask, particularly if I am on the plane. Sometimes I double up. And I still wear my mask if I'm in, which I don't normally go to, but if I'm in large crowds, I still wear my mask for myself. But just going to the bank, which is doesn't happen often, going someplace where there's, it's outdoor, I tend not to. But I'm very aware, still keep my mask in the car just so that I can always be prepared. Shaking hands, and I wash immediately. So still taking precaution. I just don't know how many people are still hyper alert about that, particularly in our community.
Yeah, I think it's going to be an individual option kind of thing. But two other observations. One would be taking good care of the organs that you can and showing up for preventive care types of things or checkups might be a good idea. So you don't get surprised that, oh, I not only have COVID, but I have kidney damage too, or something else happened.
Or pulmonary hypertension now.
Yeah. So that having the a message of encouragement to do routine care, checkup types of things for individuals with sickle cell disease, not just like, I don't feel any problem, so I don't go in. There are silent things that could be detected and treated earlier. The other is that, this is a shameless plug, is that one of the messages through these two presentations was we don't have enough data on people with sickle cell disease. And in large part, that's because there is no registries of sickle cell disease. In the countries that did, such as France, they could just hit a button and collect information like that. But here we have no such thing, or we have overlapping duplicate counts. Like there's some people who are probably in 4 databases, and then there are other people who are in none. So there's some attempts now to have registration for different signups for different registries. And you will actively hear about those in the next year. So it does feel bothersome to some people to, have myself be in some big computer. But the trade-off is it allows you to get information about questions that otherwise there is no answer.
Thank you. So I'm going to, at this time, ask you both to give a quick, as we wind down, what would you like to leave the audience with that they can take home?
I guess I would leave the audience with some optimism, because I think that there was a lot of fear in the beginning. There was a lot that was happening, and for good reason. We were very worried ourselves as healthcare providers taking care of our sickle cell disease patients. I would say that we're seeing a lot less of severe disease for sure in our sickle cell disease population. Very few people are coming into the hospital with complications like acute chest. So I think that everything is looking brighter for sure. Do everything that you can to make sure that you can stay safe and not get COVID or get a vaccination, or even something like Paxlovid early on if you do happen to get COVID infection and you have sickle cell disease.
Thank you.
Sounds good. Yeah, so I would say get vaccinated if you haven't. Get checkups and consider signing up for a registry. This is Dr. Sue.
And on that note, for the registry, it would be wonderful if we just had the one like we have the cancer registry, which is so genius in how it's done. And so I think if people were interested, they don't know where. I know that we did the Get Connected. We're actually still part of that.
Okay.
But
that's big.
As you said, registries, and I have to even admit, I'm not even aware of the other 3 or 4 that are out there for people to participate in. So that's something that perhaps if someone can share, we can actually post that on our e-newsletter or something.
Okay. Thank you for that reminder and challenge. We'll work on that.
Thank you.
Yeah.
Oh, any other, I think I heard someone, final questions or thoughts from the community? All right, well, I want to thank you all for spending your afternoon, evening with us. And we're very excited to share this information. We hope that you can take it back to your studio, back to your community. So we're thankful. I do want to be able to mention again that we are thankful for the sponsor. Make sure I read it correctly. This is sponsored by NHLBI. They were the prime sponsor, and the subrecipients, UC Irvine and Cayenne Wellness Center, as part of their SEAL Award, CEAL Award. So thank you all for joining us, and that concludes our first Wednesday webinar.